Let me introduce our panel today. I'm going to start with our moderator, Dr. Alana Yalo. Dr. Yalo is the Chief Academic Officer of KinderCare Education. As you may already know, KinderCare is the nation's leading private provider of high-quality early learning education, and its parent company, KinderCare Learning Centers, KinderCare at Work, and Champions. Welcome, Alana. Our next speaker is Dr. Joelle Simpson. Dr. Simpson is a pediatric emergency medicine physician at Children's National Hospital in Washington, D.C., and serves as the medical director for emergency preparedness. She is on the American Academy of Pediatrics Council on Children and Disaster and is board certified in pediatrics and pediatric emergency medicine. Thank you for joining us today, Dr. Simpson. Our third panelist or speaker today is Dr. Tress Goodwin. Dr. Goodwin is an emergency medicine physician at Children's National Hospital and serves as assistant medical director for emergency preparedness. She is board certified in emergency medicine physician, serving both adult and pediatric patients. Great to have you with us, Dr. Goodwin. So what I thought I would do is we spoke 4 weeks ago. For some of you who might have been a part of that call, we had a very similar question presentation webinar. And today the doctors have kind of where we are today in a ever-changing environment of COVID. They have where we are today. And so I'd love to turn it over to the doctors to give us an update in what we know today. Thank you.
Excellent. Thank you for having me back. I guess it was a treat to present last time, and we look forward to answering your questions in this webinar. We'll start off with talking about the prevalence in kids and where we are from where we came from a month ago when we presented. We will talk about the impact of the transmission rates and risk factors that we're seeing in kids and adults, and then talk about the ways we can continue to prevent transmission. And a little bit of good news about things to think about as you think about reopening, whether a hybrid model or full reopening in person for your schools. So we'll start with the first slide, which is basically to disclaim that, as we've noted, even from a month ago when we talked to you, COVID-19 continues to evolve. Its impact on kids, impact on our communities has continued to change, and we're in a different state today than we were a month ago. So please bear with us. We know the science is changing daily. One of our goals is to hopefully distill some of that science and some of the facts we know from the medical side and what you're seeing on in your literature or in the news, and sort of try to make sense of it for you. Next slide. So starting off with the prevalence in kids. So a month ago, we spoke to you, and we, at that time, were talking about our population seeing a decline in the average cases being reported. Well, since the middle of June, we're starting to see a little bit more of an uptick in cases. And so we're in a completely different landscape than we were when we first spoke to you a month ago. The next slide, though, talks about what this means with regards to children. So next slide. One of the greatest sources of information regarding kids cumulatively across the country has been from not just the CDC, but the American Academy of Pediatrics. What we see here is that since July 16th, we have continued to have a lot of cumulative data being collected by the states, but not necessarily in equal formats across the states. So take that with a grain of salt. On average, we see that 8% of kids are impacted or are affected by COVID-19 in terms of a positive diagnosis. But the way that states are collecting data has varied for a number of reasons, whether it's the accessibility of testing or just sort of the supply chain and different barriers or opportunities that various states have. So the next slide talks about also how states are dealing with reporting that data. Some states are highlighting data only between 0 to 14 years of age, and what we call pediatric has varied even across pediatricians. So when we think about the studies that are coming out, it says it affects kids. Think about whether or not when you're interpreting information for your state, where here on this map it shows how your state has been reporting data for kids, and so how it pertains to the population you're trying to answer questions for. In general, the majority of the states are reporting for the 0 to 19 years of age range. And so that's really important. But we put the link at the bottom of this slide here so that you can also check with the American Academy of Pediatrics that collates this data with the CDC across all the different states to be able to better keep track of what each individual jurisdiction has been following in terms of reporting pediatric data. So that's just sort of distill some of the information, but let's move on to talking about transmission rates and risk factors, which Dr. Goodwin will lead.
Thanks, Dr. Simpson. So we last spoke again, looking at the various age ranges, and for you and for your population, it's going to be primarily ages 5 through 18. So as you can see in this graph, there are higher numbers of cases in the older age ranges, and in the under 1 year, there are higher rates of hospitalizations. But overall, there are low rates of hospitalizations in all ages. And just keep in mind, in that newborn, less than 1 year, a lot of times the hospitalizations are based on the fact that they're more vulnerable, and that all babies under usually about 2 months with a fever will be hospitalized. So of note, this study is from February through April 2nd, and this is the best data we have so far. There's no good comprehensive studies that have been done on children in a while, and we eagerly await more information. But as Dr. Simpson pointed out before, this is challenging with all of the variability in the state reporting. So we're hoping that there will be better studies out there as we move forward. But right now, we can again confirm that the higher rates in older children, but overall low rates of hospitalizations. Next slide, please. So if you remember way back when, a month ago, we kind of painted a rosy picture that based on the studies we had, the children didn't seem to transmit the virus very much. Well, the best study that came out to date was published from the CDC, and it's from Korea, and they did an excellent study, and it was very rigorous, and they identified almost 6,000 cases from early in the pandemic in South Korea, and they traced those back at these index cases that they called them, and they found out that indeed the children can transmit the disease, and that older children, so that the 10 to 19 year kind of middle school and high school range, they transmit at similar rates as adult. But for whatever reason, that under 10 were less likely to contract and transmit the disease. So this was, again, an important caveat to note, is that this study was based on when the younger children were quarantined at home. So while they are lower risk of transmission, this might be wiped out when they return to their normal small child interactions, which, as you know, involves lots of touching and close contact. So a question is, why are the younger children less likely to spread COVID-19, and why do they not appear to be as sick? And there's no good data on this. We don't know, but some thoughts are maybe because they're shorter and smaller and they physically exhale less air, so therefore less air with the virus. They're closer to the ground, and so they don't transmit the virus to taller people and adults. Do they have differences in the cells of their lungs? Are these cells immature, and therefore they don't impact they don't get as much virus? Another interesting hypothesis is that the common cold that you know, having been around children a lot, is that children seem to get multiple colds every year. That's actually those are almost always coronaviruses. Now, not coronavirus 19, not COVID-19, but other kinds. And is their body primed to kind of fend off from these common colds? And so therefore it's more like a common cold. We don't know what the answer is, and there's a lot of research ongoing, but that's where it stands right now. So transitioning to adults. And so this slide, we're going to review what this risk factors are for adults and severe disease. And severe disease is meaning hospitalized and portraying for worse outcomes. So we know this is relevant to you because of your staff, we're all adults, as well as for your families of your students, because they have to determine what puts them at risk at most, depending on who lives at home. So as you've heard before, older age and age is the most significant risk factor, and that is much more increased at greater than 65. So in fact, 8 out of 10 deaths from COVID-19 at this point are in patients older than 65. Other confirmed risk factors are obesity, and we're talking in a BMI of 30 or higher, type 2 diabetes, heart disease, and kidney disease. There's another list that's more expanded that you can access on the CDC website, but these seem to be the most relevant to your population and the most prevalent in terms of risk factors that are out in the population. The second column talks about additional risk factors, and these are purported and possible, but not confirmed. And what's been interesting is that asthma, even moderate to severe asthma, hasn't really been shown to be a confirmed risk factor. It's shown up, but based on their modeling, the risk of asthma having severe disease is a lot less than they thought. It's possible, but right now the data doesn't show it. Other conditions, high blood pressure, which often can go hand in hand with type 2 diabetes and heart disease, but standalone high blood pressure is a possible risk factor. A big issue that I'm certain will impact your staff and the families is pregnancy. And there's still much debate about whether pregnancy is an additional risk factor. Smoking and type 1 diabetes are also possible risk factors. We hope to have more data as this bears out, but right now this is what we have published. So in terms of children's risk factors, they're pretty much the same as adults, and the most relevant ones that children would have would be obesity. And again, this is the biggest risk factor for adults, besides age, and is also bearing out for children as well. And in fact, asthma, that would be another very relevant condition. Remember, that is an additional and not confirmed risk factor, but something to consider. And then for your more complex kids, and some of your children that would be in special education with medically complex, multiple issues, they are also at increased risk. It's hard sometimes to tease out why is that. Is it because they are more likely to live in a nursing home, have multiple contacts, have nursing that might come to their home in and out? But regardless, we are concerned about our medically complex kids. And that also includes those with congenital heart disease and then other conditions like neurologic, genetic, or metabolic conditions. So I'm going to pass the baton off to Dr. Simpson, who's going to talk to us about how we can prevent transmission.
Yes. So what we've also been seeing and what we've gotten a lot of questions about has been the importance or relevance of temperature checks. And there are a lot of state jurisdictions and departments of health that are recommending temperature checks. You've seen them at restaurants, and certainly there's been discussions about temperature checks happening in schools. Well, here's some things to know about that. Individuals with mild or nonspecific symptoms may not realize that they are infected, right? So, and what we know is that a fever has only been present in about 43% of the cases that we have identified positive for COVID-19. So screening and health checks are not a replacement for other protective measures such as social distancing and hand washing, as we've discussed before, but relying solely on temperature checks as a measure of whether or not someone may or may not have COVID-19, as we've discussed before, may not be a fully reliable thing to have as a cautionary measure in terms of entering your facility. Overall, we do know that schools need to comply with the local requirements and guidelines because across the board, within many public jurisdictions, there's a lot of recommendations for temperature checks. But we do want to remind you of our earlier webinar and even today, continuing to reinforce social distancing, hand washing, wearing masks in order to reduce the risk of spread otherwise. So that being said, some of the things that we've been doing in the healthcare system and in other settings has been to think about things like self-screening. This may be an important adjunct to temperature checks and can be something that all staff can do, and certainly can be something that you can encourage families to do. And it's somewhat something that you probably did prior to COVID-19, which was the idea of making sure that parents reported whether or not a child had a fever or ill symptoms before they came to school that day. So consider focusing screening questions on new or unexpected symptoms that might have developed in the kid or in your staff that are related to COVID-19 that have been issued on the CDC guidelines, such as fever, new cough, difficulty breathing, sore throat, muscle aches, vomiting, diarrhea, or certainly new loss of taste or smell is very specific and can be indicative of a reason to potentially stay out of the school system until there's been some quarantine time or identification of whether you're positive or negative for COVID-19. One of the ways we've been doing this self-screening in our system has been to use a mobile application. It's been working quite well, but there's many different ways to do that, whether it be via the web or just a self-reporting phone system. So just something to consider in addition to the temperature checks. The other thing we wanted to talk about was asymptomatic and pre-symptomatic spread, because we do say that only 43% of patients may have a fever. So how do you know anyone might potentially be carrying COVID-19? Well, what we have been seeing in the data is that infectiousness can start 2 to 3 days prior to symptom onset. So 2 to 3 days before you even have a reported symptom, as we listed before, you could potentially be spreading the virus if you've been infected. Now, the peak infectious period can happen about 0.7 days, so within a day prior to symptom onset, and usually declines within 7 days after onset of symptoms. However, 44% of transmissions can be believed to occur before the patient has symptoms. And in some ways that can make sense because someone would not know to avoid certain measures like going into the school or restaurant or whatever the public space might be, and being sort of extra vigilant about interactions with others if they have no symptoms. And so that's why being consistent with the measures that we talked about is extremely important. We know from the flu that the peak infectious rate is 1 day after symptoms present. So this sort of correlates very nicely with COVID-19 in terms of how you continue to reinforce in a consistent way, with or without symptoms, that people need to be very vigilant about the precautions that they take. Next slide. We have a graphic here that describes a little bit more of this in detail. So if you focus on the blue arrow, which discusses, sort of highlights where a person might develop symptoms, you can see that the infectious period, as written on the right, can be 8 to 10 days around that time frame. So that means, as we discussed, that you could have been exposed to the virus up to 2 weeks prior to having your first set of symptoms and could be infectious to others also prior to showing your own symptoms at all. And one of the things that we talked about in our prior webinar was the period of quarantine and isolation and where the differences are with that that have been advised from the CDC and so forth. And typically, as you can see here, how that number came to be, you may be ill for 10 days, can be longer, but when you have no more symptoms for an additional 3 days, that's how we calculated up to about 14 days of isolation before re-entry back into the community, and the period for how they determine the quarantine. Next slide. So we cannot restate this enough. The measures for protecting ourselves is so important, and masks truly do help. And we'll show you some data about that and what we've learned within the healthcare system. We do know that if you're a COVID-19 carrier without a mask, there's a high risk of spread. But if you go to the bottom of this and you're a COVID-19 carrier with a mask and you're a healthy person with a mask, that risk of spread is tremendously lower. I tend to think of this in parallels to sort of wearing a seatbelt. If you're in a car, you can be driving and you'll be quite safe. But we do know that if you're in a seatbelt and all passengers in a seatbelt, you can truly reduce harm to everyone in the car at the same time. So the more that each of us take it upon ourselves to encourage not only practice these safe measures, but also to encourage others in our immediate space to practice the similar safe measures, then we make it a lot safer for our entire community and our staff and children. Next slide. This may be a little bit of a busy graphic, but let me walk you through it so it makes a little bit more sense. This is sort of a study that was done in Mass General Hospital in Boston, and it was study published in JAMA, the Journal of the American Medical Association. And what it shows here is that pink highlighted area where there was no prior masking, there were no recommendations prior to that point, so that was pre-COVID, of at least pre-pandemic declaration of healthcare workers being asked to wear masks. Now, as soon as healthcare workers started wearing masks or were asked to wear masks, the purple area shows where there shows to be sort of a more plateau of the amount of infections that were caught or tested for positive COVID-19 at that within that phase. However, what truly made a difference for a downslope of the amount of positive infections, you can see in the green area, which was when universal masking was also asked of patients. So when you have both the staff and the patients, or in your case, families or students wearing masks, we relate this to saying that that's when you optimize your chances of lowering the rate of potential spread within your facilities. Next slide. So who should likely not wear masks? We spoke about this a little bit in our prior webinar, but really important that as have been stated by the CDC, children under 2, kids with special needs or sensory disorders, the severely handicapped, or any physical disfigurement. Some of this is largely because there can be, for instance, strangulation risks with the masks for kids who are not at that developmental stage to understand the proper usage of it and how to keep it on. And so, you know, it not only is wearing the mask important, but wearing it appropriately is also important. And so these categories may be sort of the different parts of the population that would be excused from wearing masks. But as Dr. Goodwin mentioned before, particularly for the children under 2 and smaller kids, the risk of spread among them may be, we think, hypothetically much lower given their physical characteristics and what we've seen in the study in Korea, but something to take into consideration. Next slide. And so what kind of masks are best? There's been a lot of information about this in the social media. We know that surgical and medical masks are light and often well tolerated. Dr. Goodwin and I both wear these type of masks at the hospital, and they've traditionally been worn most often by our surgeons and when we're doing procedures that need to be under sterile conditions, for instance, and they can be quite tolerable. Homemade cloth masks can also function quite well, and we'll give you some information about the guidance we've seen around optimal homemade masks. And the idea around the risks of wearing masks in terms of affecting your ability to breathe and so forth has generally been debunked in the medical community. There may be some small exceptions that can be discussed with your personal physicians, but for the most part, masks can be well tolerated. If we move to the next slide, we'll talk about how the recommendations made by the WHO about this 3-layer concept in order to optimize the protection that masks can provide. One of the, so the criteria for if you were to have your own homemade mask, wearing a reusable mask, is to have these 3 layers: an outer layer that prevents droplets, a middle layer that can block the virus, and then an inner layer that can absorb moisture and saliva. This is available on the WHO website and would be criteria that you can look for to optimize the type of mask that you select for yourself or your staff. Next slide. Another question that we've seen quite often has been the idea of keeping kids safe while on the school bus. We've seen a list of these recommendations in our search and think that they are worthy of considering as you advise your school bus systems on how to keep staff and kids safe. One thought is to keep the first 2 rows blocked to protect the driver, but also having the kids, if the option is available, to enter in a rear or middle door. We use a lot of visual cues in the hospital system to remind kids and families of these distancing measures and so forth. And that can be highly effective, encouraging children to wear masks. And we're starting to see, even in our communities, that children are starting to mimic adults who are wearing masks and doing so more often and more consistently. Also staggering rows and seating positions, keeping windows open if that's an option that's available, and disinfecting after each run can be highly effective in reducing viral spread. Discouraging gatherings of drivers or of students as best as possible when entering the bus is highly recommended. A lot of these measures are things that we do for our own shuttle system throughout the hospital and have been quite effective, not just to reduce spread, but also to reduce anxiety among our staff and patients and parents once they see these visual cues and behaviors being triggered. And so it allows everyone to be sort of more compliant with the new culture that we're living in due to COVID-19. Next slide. We'll move on to some of the good news that Dr. Goodman is going to share with you.
All right, thank you, Dr. Simpson. So there's a lot of kind of frustrating and challenging information we've presented, and wanted to give some reason for some optimism. So vaccine, we all know that that really is going to be hopefully our ticket to an exit from this new kind of miserable reality that a lot of us are in, or all of us are in. So there's lots and lots of news about this. The Operation Warp Speed that's being pushed by the government is really accelerating the development of vaccines unlike any time we've ever seen. Currently, there are 23 vaccines in clinical testing and 3 are in phase 3. So just review, a phase 3 is the final phase before the FDA review, and that is expanded to several thousand people to look at safety profiles. So after phase 3 is done, which could take several months, FDA will review it, and based on that, will approve it or not. And then phase 4 is actually when the vaccine is rolled out. And within that, there'll be obviously a lot of long-term monitoring. So the optimistic outlook is early 2021 to really get maybe that phase 4 going. In terms of who will receive the vaccination first, right now the thoughts are prioritizing those at highest risk. So elderly, some of the medical conditions that we talked about, as well as frontline healthcare workers. Children, unlike other vaccinations, will be likely the last group to receive the vaccination. So this is just something to think about in terms of schooling. However, with adults, if adults do get it at high rates, we can hopefully establish some kind of herd immunity that will then help protect children, given that we will be able to decrease the transmission rates in the community. And typically this is the other way around, that we have children and they help create a herd immunity, but this is just a different disease, and we are learning as we go. One important note, vaccinations save lives, not vaccines. So the vaccine could be available, but until people actually get vaccinated, that's going to save the lives of our community. So another important and possibly good news in all of this is we keep talking about, you know, having a cold season and having a flu season, and that is consistent every single year. However, given what we're doing right now with all of our measures to prevent spread of COVID-19, there's every indication that if we continue that, we won't have a bad flu or bad cold season because those measures prevent transmission of all diseases, of all of these infectious respiratory diseases. So this is a pretty compelling graph. If you look at the left side, that's a typical flow for a flu season where you have a ramp up and then you have a ramp down, and it takes several months to really have the decrease seen in flu. If you look at the right graph, that is this past year, so 2019 to 2020, which in every measure, it was a pretty bad flu season. We had a really high peak there, and it literally fell off a cliff in the second and third week of March. It just dropped dramatically. And we really think, we know that's because the measures of COVID-19 forcing people to be more vigilant about hand washing, masking, and quarantining really caused it to fall off. So this is one silver lining in an otherwise pretty dark cloud. So again, we know that you're in various phases of preparation to reopening, but as you know, the preparation starts now. And some things that we really do recommend based on things we found and techniques we found at the hospitals are the importance of communication. And I know I don't need to tell this audience that, but communicate with your teachers, with your families. Again, be open and transparent about what your plans are, about what you don't know. A big thing that you can do is encourage families to start at home, practice at home, start teaching their kids how to use masks, normalize it, have them wear it out in the community. Find masks that they like, find designs that they like. There's tons out there, as you've seen. Modeling hygiene practices, talking about hand washing, really reviewing and the practices that they're going to be doing during the day when they do go back to school. It's also really important as a community, and again, I know that you know this, that in order to open schools, people really need to prioritize it and take the measures that we know work. So reducing high-risk behaviors, really encouraging people to only do the activities that they need to do, limiting their interactions with others, keeping safe social, physical distancing, because we have to get this under control before we can even consider, any broad-scale reopening. And also importantly, encouraging families to get their regular vaccines, get the flu vaccine when it comes out. Even though we might not have a bad flu season, let's do everything we can to make this a less painful and less risky winter. And then also importance of regular health maintenance. Our pediatric offices are open and they want to see their kids. They want to make sure that they're doing well. And as a school, putting that message out that maintaining regular health maintenance is still very, very important. So one thing to think about is we've all seen these infographics. They can be quite effective, and think about possibly creating your own, putting it out there. And these are the big three things that have been shown to work in multiple studies is wearing a mask, physical distancing, and we like the helicopter arms. If you tell kids about helicopter arms, if they keep that distance away from their friend, that's a pretty good measure of physical distancing. And then washing hands and really getting that message out now and getting it out consistently will really reduce your risk as you move forward to open schools. So now we're going to transition to some questions.
So I'd like to thank you both for all those great insights, and I'd like to keep the dialogue going with some questions. I'll start with some that came in advance of the webinar while our guest is submitting some of their own questions through chat. So the first question I'd like to ask you is about some of the international studies we've been seeing on school openings. The last time when we were together, we thought we might learn quite a bit from school openings in other countries, given their timing on opening before we might. But given where we are today, how useful are those studies in guiding our decision-making here in the U.S.?
Yes, that's a great question. And yeah, we did say a month ago that we'd hope to learn from other schools in other countries. And I think we did learn, and we learned that the transmission rate has to be low. The prevalence within the community has to be low. And we cannot even compare ourselves to these other countries until we've established that rate. So certain countries have done very well and have not seen many increase in any transmission, significant increases in their schools. A lot of these are European countries. Germany has done well. But again, when they opened, they did it very progressively, and they had a very low baseline rate. For example, Israel did not have a good low rate when they opened, and they saw several outbreaks from their schools, and they had to close again. So I think we have learned from them, and it just shows us that the community rate has to be low in order for us to effectively and safely open up.
Thank you. You spent a fair amount of time talking about masks, but we got a ton of questions about them, some of which you addressed, but I'd like to ask you a few others. I think you did mention briefly, but are there any health risks for extended use of masks in either adults or children?
So there are no reported consequences. There doesn't really seem to be any relevant health impacts. all of these symptoms that people report are subjective. So just to back that up, the American College of Allergy, Asthma, and Immunology, who issues guidance, says there is no evidence that wearing a face mask makes asthma worse. However, it is possible with people with asthma may feel it is more difficult to get an adequate breath while wearing a face mask. So you have to remember there's a difference between what subjective symptoms are reported and an actual relevant physical burden. And just in the healthcare space, surgeons wear masks, the surgical masks, we call them surgical masks because that's who wears them, for hours on end, and there are no reported any issues with long term. Again, it's something that you have to learn how to tolerate, but that has just not been borne out in any data at all.
Thank you. And I do have some more questions on masks, but we did get a question from one of our school administrators. So this person is a school health manager, and she's very concerned that the school nurse staff is short now. I think the question is there anything that we should be doing in particular to support school health nurses above and beyond what we're doing to support other staff?
And this is due to because nurses will be in high risk areas.
High risk, and also she indicated that her nurses are actually in high risk categories themselves.
That is a great question. And in terms of, we can't obviously limit their contact with everybody, but things can be done to increase their PPE. So when we have someone at high risk, a staff member, we actually encourage them to wear the higher grade masks. So those are the N95 masks, and they are more uncomfortable, but that really reduces the risk of transmission. In addition to a face shield. So for nurses that are going to be in high risk areas and are high risk themselves, if it is determined that they should and do need to come back to work, increasing their level of PPE, looking at the physical setup of the nursing office. So can we keep these kids, at least a separate, a larger distance apart from them when they're waiting, not keep them all close in close quarters. All these things can be done to lessen the risk and should be considered.
Thank you. This is probably a follow-up question, relates to the use of masks, but there's also been a lot of conversation about the use of face shields in general. Can you talk a little bit about the importance of masks versus face shields, or both, and how should we be thinking about that?
Yes, absolutely. So early on, again, we feel like this has been a decade. So early in the pandemic, we talked a lot about face shields. There's a lot of news about that might be a great alternative. And that was when we really thought it was a droplet transmission was the primary way people were becoming infected. But more and more data is showing that it's aerosolized, meaning it's very small particles. So as you can tell, when you wear a face shield, the risk of getting the air is going to go underneath and around. The face shield just does not provide the same level of protection as a mask. So this would be of high risk if you're in a classroom and the small children who can't wear a mask. If a teacher only has a face shield on, this would put them at high risk. So at this point, the CDC and other data does not support wearing a face shield alone. However, it can be an excellent additional level of protection. So for someone that's at high risk, wearing a mask and a face shield would be a great use of extended and extra PPE. But alone is not recommended, just given what we know about the virus. There are some innovative masks out there that you can find on, there's some professional grade ones, as well as on Etsy and sites like that have a small see-through window over the lips that's really helpful for lip reading and hearing impaired people, as well as if we think about smaller children and their need to really look at facial expressions and lips, that might be a great alternative. But the most important thing is that there's a seal all the way around from the chin to the bridge of the nose and to the cheeks that face shields just don't provide.
And Dr. Goodwin, can you talk a little bit about the use of goggles or protective eyewear as well?
Absolutely. So we have at the hospital mandated eye protection from the very beginning. These are just wraparound, and that was really more for kind of the droplet. There is not great evidence out there that that the eyes are a high source, but there is good evidence that's showing goggles in addition to masks would be a great would be recommended, and we recommend. It's not that difficult. The face shield is also excellent because it can provide that eye protection. Prior in other illnesses and other infections, we do know that the eye can act as a route. However, it is showing that most likely the kind of nasal and the oral passages are the most common routes of infection with COVID-19.
Thank you. And we have another mask question. Can you talk a little bit about whether or not it's safe to wear a mask during physical activity?
Absolutely. So pulling directly from the CDC website, they absolutely do not recommend wearing a mask in activities that would cause the cloth face covering to become wet. So that's like swimming. And I think that makes sense to all of us. A wet mask would be very difficult to breathe through. They do also say that in people engaged in high intensity activities, and we're talking running, it might be difficult because it could have the subjective feeling of difficulty breathing. I've seen plenty of runners here running with masks on. I think that's going to be kind of up to the schools. But again, the wet is not recommended. A lot of these activities we'd imagine would be done outside, so that does decrease the risk. If you're outside and running with adequate physical distancing, considering not having masks if it's high intensity is okay.
And I think I have one final mask question, and then we can move on. Is it safe for children or adults to reuse the mask? So if they take it off while they're eating, can they put it back on? What are the recommended procedures around reuse?
That is a really good question. So the most important thing when you think about your mask is what you're touching. So this is another really important thing to talk about before reopening is being really attentive to what you're touching and how you're moving it. So removing based on or using the earpiece and setting it down. We have paper bags for all of our staff that we label, and they can take off their mask, put it in there, and then put it back, really trying to avoid touching the front of the mask, because that's where potentially any of the possible infectious particles would be, and then being very vigilant about washing your hands. So every time you take off your mask, and this is most likely going to be prior to eating, you're going to want to wash your hands. We do use the same mask all day long. So for our surgical masks, we use them for an entire shift and then we'll throw them away. With the cloth masks, it's reasonable to think about using them all day and then washing them.
Thank you. So moving on from masks, we've all heard a great deal about the differential impact of COVID-19 based on ethnicity, socioeconomic status, race. Can you discuss this and what we do or don't know about, why there are differences or maybe differences?
Yes, that's been a large topic, I know, in both the medical literature and social media and the lay press. And I think a lot of it is still being sorted out right now. We're actually expecting that a couple of publications are going to come out about these disparities, particularly focused on the pediatric population, but we're extrapolating a lot from what has been shown in a lot of the adult studies, which is that, I think a lot of it comes back to some of the same measures that we've been talking about and the ability for some communities to be able to comply with those, just given the concerns that they have for the conditions that they live in, whether it be that there's more people living in one household, so the idea of social distancing, or the availability of or access to masks and resources may not be as readily available as in other communities. And then when there's a cluster or outbreak for one particular family member that then spreads to others, then sort of that multiplier force is that much greater, which is how we're seeing some of these outbreaks be impacting certain communities more than others. So my answer there is that there's more to come. I certainly know that this is an area of key focus for the American Academy of Pediatrics. And of course, the CDC has written a lot about it. Whether there is a genetic basis for high risk, not sure, but certainly we know that the disparities that have existed for other conditions, which are some of the high risk factors Dr. Goodwin mentioned, such as obesity, hypertension, diabetes, et cetera, those also follow race and socioeconomic sort of differences. So therein lies some of the reasons why we might be seeing that exacerbated by COVID-19 as well, not to mention a lot of the things related to the other stressors COVID-19 has brought about other than health, which is maybe some of the financial pressures, some of the loss of jobs, the ability for families who have sick relatives and so forth, who are not as, don't have as many resources available to be able to distance themselves when a member becomes sick of their family. So all of those factor into why some communities we're seeing more vulnerable than others. I think if you have families that you are aware of in your school system that are facing sort of some of these issues, I know that there are school systems now discussing ways that they can do targeted outreach, have food supplies available, have care kits available, be able to provide, and I know many of your school systems have been providing sort of the technology that the kids need in order to do the distance learning. And many schools are weighing the sort of risks and benefits of the safety of opening schools or the safety of some kids being home when they're not getting the resources they need to continue to stay safe during this COVID-19 pandemic, not just from COVID-19, but all the other stressors that their families are facing. So hopefully by the next time we're able to talk to you, we'll be able to come up with some more sort of concrete ideas and best practices, so to say, that have been being employed around the country to address this very issue.
Thank you, Dr. Simpson. It's great to know that we're getting current information in real-time basis. We talked a little bit about school nurses, but can you also discuss safety precautions for schools that are, one of their critical roles is to serve nutritious meals or lunches to children, talk a little bit about space requirements, protection for the staff, any insights for that critical function of schools?
Yeah, so we've seen when schools shut down in March, a lot of communities have responded with grab-and-go meals available at various community sites. And as the school year kicks off, that need is going to continue and perhaps even grow as financial insecurity is more pervasive. Unfortunately, with the cafeteria and the communal style dining halls are just not a risk. It is inherently a risky type of interaction. So the recommendations really are to have children bring their own meals as feasible, and then serving individually plated meals in classrooms. And I know this adds a significant logistics barrier and challenges depending on whether there's multiple floors in a school and just the thought of rolling all of that out. As awful as it is for the environment, they do recommend using disposable food service items. And if that's not possible, then the dishwashing procedures just have to be used with extra care in terms of not wanting to infect those that are responsible for cleaning. So I wish I had a great, wonderful answer for that, but unfortunately it's really looking like eating in the classrooms is the way to go, at least at this point.
Thank you. Another question that we got on chat is, what do you expect the impact will be on the change of reporting public health data to HHS instead of CDC? How does that influence what we may expect to be seeing?
So that's an interesting question. I think that's something that even us in healthcare are also concerned about. We know that the CDC, across many countries that have a CDC as well, are usually the sort of the the masters of the public health data and being able to disseminate that information. It's what they do well. And to transition that to another federal agency that may not have been their usual task is concerning for the public. Fortunately, we don't have the insights to know what preparations and what accommodations are being made for HHS to transition that role. We hope that it's being done in an informed way, but as that happens, do know that those of us, particularly in healthcare, and we hope those of you in the school systems as well, will advocate as best as possible if we see that there's flaws with that system that aren't working out. So we here in Washington, D.C., we are definitely keeping our eyes on all of that and are going to speak up if there are any things where we think it will be a threat to our kids or certainly to the public health in general.
And,
Well,
and
thank you for that.
I think this also points to what a really important role that schools will play in this. That what the only way we're going to learn from this is to get good data and working with your schools, working with your local health districts and statewide public health system to really work on and develop a good reporting system, I think would help elucidate a lot of these unknowns. And even more so now that we don't have this centralized, we don't know what's happening with the centralized reporting system, to hope that states and in turn more municipalities can step up and make sure that the information that we absolutely need is getting there.
Well, thanks for the insight, and we'll be counting on you to help keep everybody well informed. There's actually another question that's an interesting follow-up. Is about the role of social media and getting information to the public quickly and in keeping people safe. Social media is a big landscape, but do you have any thoughts on that?
My advice, and both Dr. Goodman and I have used social media to some extent, but to share information with our colleagues. Those are usually in closed sort of networks with our staff, for instance, for the emergency department that we work in. But be very, very cautious about using that measure. It is often very easy to, for instance, forward a message that seems catchy and impactful. But what we were able to do was have really even, we had sort of our communication group that were strictly charged with vetting information, being sure that we all made sure that the different ways that people could interpret the message would have been as accurate as possible, and distilling the message in a way that was impactful and not sensational. So it is a very difficult task to perform when it's sort of across a large group of people. I would say my best advice would be to select maybe 1 or 2 or 3 folks within your system who that is their task, is to think about the most current headlines, think about the critiques of those headlines. And we tried to offer some examples of thinking about, where did this if you're looking at data about children, where did this children's data come from? What age groups are they covering? Does this really apply to my school system? Is this a message that is really applicable to my families or to my teachers in order to be relevant to them? Or if it isn't, explain why it isn't, which is what we try to do every time we talk to our staff. What our experience was in DC was that we were well behind New York, for instance, that had a lot of sensationalized headlines, some of which were accurate because New York did hit their peak much higher than a lot of other states. But of course, the panic that ensued, reasonably so, in our staff was sometimes unfounded in some of the measures that they wanted to take before we even had sort of a peak in our COVID-19 cases as they did, and which was dangerous in some ways, because while we want people to be cautious, the overuse of PPE or the concerns about not coming to work and so forth can have a domino effect and impact on our patients and on the system in general. So communications is extremely important, but needs to be done with sort of expert eyes in a very calculated way.
Thank you. I know we're almost out of time. We do have a couple of last questions that have come in. I hate to say it, but another mask question. So maybe quickly, is it recommended for the children wear masks when playing on the playground, even if we believe that they could practice social distancing?
Yeah, I do think it's important. They're going to be most likely closer to each other when they're on the playground, even if we want to say that they'll be 6 feet apart at all times, they won't be. So I really, yes, I think making it consistent that children wear masks, and they really do. I mean, we know kids are resilient, and I think if the modeling and the education starts early, it's something that they'll just take in stride and continue to play.
Great, thank you. And maybe one last question. So there was a question on nebulizer treatments for children that cannot use an MDI inhaler. Any thoughts on that?
Yes. So one of the phrases we haven't used yet on this webinar has been the idea of aerosolized generating procedures. And in our healthcare system, we consider nebulizers a mode of which you can aerosolize particles. And as Dr. Goodwin mentioned, we originally were thinking about COVID-19 as a droplet type of dispersal, but it's really seen to be more of an aerosolizing dispersal that can increase its infectiousness between people. So what you can imagine is that if there is a child who happens to have COVID-19 and is given a nebulizer treatment, they therefore could be aerosolizing that virus. So what we do in the healthcare system is have a very increased PPE and very strict disinfecting protocols after we do the aerosolizing process. And your ability to be able to do that within the school system needs to be considered. So if you have a room that can be sort of safely barricaded and a nurse or some sort of a healthcare provider who can provide that nebulizer treatment with the appropriate PPE, then it's possible that can be considered, but it's not something to be taken lightly. The nebulizer is a very different risk than the inhaler. So that's something you would have to discuss with your healthcare personnel at the school.
And I also want to add, we initially, as healthcare providers, we often order the aerosolizing with the nebulizers. And there's a big push for us to really switch to the MDI, and you always have to use a mask and a spacer. And in fact, does just as well. So I think that should be a discussion with school nurses that might push out that information to the local pediatricians. Really, we got to get these kids on MDIs. The data shows that it's just as effective. If they really need an aerosolizing nebulizer, they should probably be in a hospital. So that's something that nurses could push out right now and encourage the students that need it to go see their pediatrician and get set up with an effective system.
Well, we are out of time, and before I turn it over to Dan to close it out, I'd like to thank you both so much for joining us, and also a huge thanks to all of our listeners representing school districts around the country who are grappling with a critical mission to educate our children, but also to keep them safe. And it's a hard challenge, and we so appreciate your work. So we hope that we've helped in some way. But again, thank you so much, Dr. Simpson, Dr. Goodwin. You are always a wealth of information. And Dan, I'd like to turn it out to you to close us out.
And thank you, Dr. Yalow, for your questions and moderating the event for us. I really appreciate that. So just a couple things really quick to close us out. Audience members, at the end of this, you're going to receive an email with a 3-question survey. Would love your feedback, as we'd like to continue these, and we want to do them. And we want to use your feedback to do them in the very best way to serve you and provide you the right information. And then for all the school leaders who are on the call, August 5th at 10, I'm hoping I'm getting this right, but I believe I am, 10 Pacific, we will be hosting another webinar. This one will be about how Champions is coming back to schools across the country. So where schools are reopening, or in cases where schools are not, but essential workforce family needs to be taken care of, we are reopening at schools. And so we're going to talk about our health and safety guidelines. We're going to talk about our curriculum for those returning students. And we're going to talk about our operations and what it would look and feel like walking into a Champions after school or a full day program in a lot of cases during COVID. So We welcome you to the August 5th event at 10 a.m. You can look for an email. And again, Dr. Yalo, Dr. Goodwin, Dr. Simpson, thank you so much for your time and participation today. I really appreciate it. Have a great afternoon, everyone.
Thank you for having us.
Thank you.
Bye-bye.
Bye, take care.